All right. So for those guys who don't know us, my name is Shanthosh and this is Ben. We are both at Nepean. And we're going to talk to you about some cases related to post-myocardial infarction complications. As you know, there's a whole barrage of different complications that can result from an MI point of view, but we're just going to focus on the echo aspects of things and complications that are that can generally be picked up on echo. So we'll start off with a case. I know it says case 3, but we'll just start off with the initial case. So we've got a 79-year-old female with no previous significant past medical history. Initially presented with 2-day history of chest pain, diagnosed with an inferior STEMI, was treated appropriately with dual antiplatelet therapy and heparin, had ongoing chest pain, had subsequent PCI to the mid-RCA. And on the right panel, you can probably appreciate, so this is the right coronary artery. The reason I know this, it's a C-shaped artery, and that's how you know it's the right coronary. There's a lesion in the mid-segment. I'm not sure whether you can see the mouse where it's a bit hazy there. So it's probably more than 70% occluded. But the segment B, they've stented it, they've fixed up the lesion, and you can see there's now a nice open lumen there. So intraprocedural cardiac arrest. The initial arrest was PEA for 5 minutes. They had CPR, adrenaline, atropine, got ROSC, had 2 rounds of shocks for VF throughout the procedure. It was quite complicated. Then had IABP inserted, and then adrenaline infusion was commenced, and the patient was transferred to ICU intubated with double-strength adrenaline and an balloon pump going at 1:1. So obviously the patient was hemodynamically unstable, and an urgent tow was conducted. Let me see if that plays. What do you guys see there? Anyone? Michael?
Yeah, so it's a mid-esophageal 3-chamber view. It's a little bit laggy for me, but I can see that there's definitely a decent amount of MR, and there's some AR as well. Sorry that I can't quite see the images well enough to say how bad the MR looks, but there's flow convergence, and it looks like quite a large jet with a scale set appropriately. I can't see any big effusion in this view. There's no big dissection flap or anything like that, but yeah, it looks like there's MR and AR.
That's exactly right. So at least the AR is not significant. It's probably trivial to mild, maybe. But the MR, the mitral regurg, is quite significant there. So, and then on this picture, anything else that you can see, Michael?
Yeah, so mid-esophageal 4-chamber, and it looks like there's a flail segment of the anterior mitral valve leaflet. I'm not sure exactly what segment it is, but there does look like there's something prolapsing into the left atrium and facing up towards the atrium rather than just being, a flail rather than a prolapse, because it's sort of pointing upwards. But I can't see, it's a little bit laggy, so I can't see with the frame rate, but I think that's what it is there.
Yeah. So if I take you to this picture, does that give you, is it a bit more convincing there?
Yeah, definitely. So, like it says in the screen, it's a 2-chamber view, and you can see just from that. I think it's still the anterior leaflet, but I'm sorry, it is a bit laggy. But I think it is the anterior leaflet that's prolapsing up into the left atrium. Flailing up into the left atrium.
Yeah, so this is flail, not prolapse. And the difference is with the prolapse is actually you get like kind of parts of the mitral valve leaflet. It's just, bulging into the left atrium. That's essentially what and then in this case we've got like the absolute, like it's just flailing where the whole thing has just ruptured off. And so what about that chunky bit that you can see at the bottom? What is that? There, where my mouse is.
Probably a chunk of the papillary muscle that's ruptured.
Yeah, 100%. And if you had to have a guess, which papillary muscle, which one would you hedge your bets on?
I'd hedge my bets at being posterolateral rather than anteromedial.
You mean
backwards?
Yeah. So am I say it right, posteromedial and anterolateral,
Oh,
and posteromedial.
yeah, my bad. Sorry.
Yeah, yeah. Okay. So you were going to say posteromedial,
Hmm.
and why is that?
It's got one blood supply rather than the other anterolateral that has dual blood supply. So it's much more likely to have a rupture and ischemia.
100%. And for bonus points, do you know what the blood supply is?
So I think it's RCA, but can be circ to the posteromedial. And
100%,
then the
exactly
other one
right.
is
So,
LAD.
I mean, what Michael said is quite correct. So the posteromedial pap muscle is most likely the one that's going to rupture because it has a single blood supply, whereas the anterolateral pap muscle has a dual blood supply from the LAD diagonals and the circumflex, whereas the posteromedial is usually supplied either by the RCA or the left circumflex, whichever is the dominant vessel and gives off the posterior descending artery. So it is the one that's most likely to come off or rupture off.
Sandra, can I ask you a question on this one? So, Mark, you may not be able to see because of frame rate and whatnot, but in this clip, it looks like you have a leaflet that has papillary muscle attached that's prolapsing back in, and that leaflet, sorry, the pap muscle is flailing back in. But it looks like the other leaflet, the mitral valve, is flailing as well.
Yeah, I mean, it could be. No, you're quite right, because with the papillary muscles, they give off essentially they tether off both leaflets.
Yeah.
So you can get a bit of flailing from both sides.
Yeah.
Whereas, but in this case, it's most likely the most posteromedial pap muscle that has ruptured off and just flailing backwards and forwards. So bit of color across, and you can see that that's quite severe or free flowing MR. And so this patient is going to be quite hemodynamically unstable in your unit. Does that make sense so far, guys? If not, if I've gone too fast or if it doesn't make sense, stop me please by any chance. And this is just the Doppler going through across the mitral valve, and you can see the severity of it with the high gradients or high velocities. So essentially, this patient had acute severe ischemic MR secondary to posteromedial papillary muscle rupture. They underwent an emergent mitral valve replacement, and a bioprosthetic valve was inserted. And this is the biopsy, or not biopsy, but I guess the pap muscle that they've removed at the time of surgery. And you can see there's a lot of red bits there, and it looks quite hemorrhagic and ischemic looking. So it's not natural. So this is an acute event. This is some post pictures there, and the reason why I know it's whoop. Let me go back. Give me a second. So that one didn't work. And so now you've got the atrium up there, you've got the ventricle down here, and the flow is much better across the mitral valve. That's been repaired, and you don't have the free flowing MR that you had initially a couple of slides ago. This is across the aortic valve, and again, even the aortic regurgitation is not that significant. It's only quite minimal. So, Michael, continuing on, since you're doing this case, same patient still. This is post surgery.
Mm. So it's a toe image again. It's a gastric short axis view at the papillary muscle level. So next to the posteromedial papillary muscle, there's another mass. It's really difficult to see what it is. The LV function looks reasonable to me, but there is regional wall motion abnormality adjacent to that mass, and I suspect it could be something like an LV thrombus. I'd be suspicious for it. I wonder if that's what we're looking at.
Yeah,
I was going to say, what walls? What walls in the akinetic?
So the inferior and infraseptal wall, I think. Yeah.
Yeah, 100%. I mean, with the toe images, it's reversed, so you just got
Yeah.
to be mindful of that compared to your transthoracic. So you can get off guard, or you can be put off by it. So you're quite correct. So you do obviously have some hyperkinesis there. To be honest, I don't know what those changes are on that, and that's where your pat muscle should be, and whether that's post-surgical changes or whether that's a thrombus. And that's a very good question. That's you got to ask that question in that case. So, anyways, the EF was 45. They had impaired septal, anteroseptal, and inferior wall. And the IAPP was removed a couple of days later. NORAD and all of that was weaned off, and they were actually sent home from ICU on day 6. So this patient did remarkably well. And I think this is probably, I mean, this case probably highlights a couple of things. One, this patient did have an acute event, but the fact is, I mean, we get a lot of inferior STEMIs and RCAs, and they can be quite sick. But in this case, obviously the intensivist realized that this patient is hemodynamically unstable. There's something not right. We need to go fishing for some other complications associated with MIs. And I think that's this case highlights the importance of the fact that they've picked up that there was a pat muscle rupture, and this patient was sent off to surgery almost that evening. So, and I think that's an important fact. Does that make sense to all of you guys so far? Great. We'll go into the next case. 75-year-old male with a background history of hypertension, dyslipidemia, prostate cancer. Presented to the peripheral hospital with 2 to 3 week history of left-sided chest pain. Suddenly worsened when they presented to the hospital, and he was essentially diagnosed with an inferior STEMI. They had a PCI to the LAD and the right coronary artery, and they had a balloon dilatation of the first diagonal. But eventually they developed multi-organ failure on 3 days after, with worsening dyspnea and orthopnea. So obviously this patient's going into heart failure. They became tachycardic with intermittent AF, hypertensive, acute kidney injury, LFT derangements, intubated following failed NIV, and then transferred to a tertiary hospital. I've got 5 images here. And if I can get someone to have a look at these images and interpret them for me, please. Anyone? Maybe Drew?
Sure. So we've 5 different views. These are all transthoracic. Top one's apical 3 chamber. Middle is a apical 4 chamber. Next to that's a zoomed in apical 4 chamber, the LV. Next one's subcostal. Another one's a RV focused 4 chamber view. Probably the key thing to acknowledge in this patient is that the RV is, in these images provided, that RV does look dysfunctional, possibly the potential for a McConnell sign, which raises the differential of an RV infarct or a pulmonary embolism. The left ventricle doesn't seem to be the source of the hypotension, as it's a reasonable size and good contractility. And there's no obvious valvular dysfunction from what I can see on the images provided.
100%. Although you would probably want Doppler profiles and color flow just to make sure that that's the case. But I agree with you. I mean, the RV does look a bit impaired and under strain. And Ben, you can tell me a bit more about it because you're the RV expert. But the longitudinal function of the RV is a bit impaired. It might be slightly dilated, but I'll probably have a couple of other views to have a look at it. And you're right. This patient has almost like a hyperdynamic LV function. So, I mean, we're still looking as to why this patient is hypertensive, has all the heart failure type symptoms, and has gone into multi-organ failure. But on these 5 images, I don't have an answer at the moment. So if I take you to the next lot of images, Drew.
Yeah.
If you take me through those images, what do you see?
Yeah. Okay. So these are this is a short axis view of the left ventricle. What you can see is that there is a 2D defect in the, I guess, inferior septal wall, which, given the timeline of things, I'd be concerned for a VSD, but would want to interrogate it a bit more. There does appear to be septal flattening of the interventricular septum, which appears in systole and diastole, indicating pressure and volume overload. But again, the concerning feature would be a ventricular septum defect.
Yeah, 100%. I mean, this is quite a difficult image, and you're quite right. So probably the easiest image are the left two images on the top and the bottom, where you can see that there's a defect in the septal region, and you wonder whether you've done, whether it is an actual defect, or whether it's just you're just capturing something else as you're scanning. And so you'd want to probably do some color flow profiles across that.
Yeah, so this color flow is obviously very concerning. There's, I think, flow in more prominent in systole, but in diastole as well, which would be what I would expect for an acute VSD, ischemic VSD.
Yeah. So you're 100% right. So what we can see here is you've got on the left, you've got that defect where my mouse is. You've got the LV that's really pumping there, right? It's working hard to try and compensate for the loss of output there. And you've got that, when you do the color flow profile across it, you can see that you've got this clear defect in the septum going into the RV. And what does this show?
You can see that there's a high velocity through this space. It's mostly in systole. Yeah, which again is in keeping with our color findings.
Yeah, and is that what you expect, clearly, like for a VSD that's mainly in systole?
Yeah.
Yeah, 100%. I mean, if you go back to your basics, if you auscultate, and then I say a pansystolic murmur, loudest in the left sternal edge, that will be one of your differentials for a VSD. And what you said, Drew, was quite correct. I mean, this patient had a delayed presentation for a STEMI. I mean, they had 2 to 3 week history of chest pain, and so obviously your thoughts of having an ischemic VSD is quite high on the differentials. If I take you through that, is that a bit more obvious there?
Yeah, definitely.
So what are we looking at here? If you take me through that, Drew, again.
So 3 different images. They're all subcostal. I think there's some atypical views just to identify that there's potentially an aneurysmic component to the mid-septal wall. But probably it's hard to say exactly where that is. It's probably inferior, to be honest.
Yeah.
And again, color flow in keeping with our suspicion that there's a connection between the ventricles.
Yeah, 100%. So, and again, you're just going through all the images. So obviously this patient was quite unstable and very sick. You obviously noted that in the history that this patient was in multi-organ failure. I'm not from an intensivist background, but what am I looking at here?
I'm not intensivist background either, but it looks like a cannulation attempt through the IVC. I'm not sure if they were planning ECMO, VA ECMO. And
yeah, very good. Yeah, this is an ECMO cannula, and Michael, you can chime in, but these patients are so hemodynamically unwell and sick that the only way to try and stabilize them is to put them on ECMO. so that's essentially what they've done. And part of the workup, this is, I think, is quite an important slide. And part of the workup they've done for the Doppler profiles. Drew, can you take me through this?
Essentially, what they're doing is that you've got the top part. Now I'm just trying to see if there was a timing difference between the two, or if this is just repeated measurements. I think just repeated measurements.
Yeah, I think so.
And it's just comparing the VTI between the LVOT and the RVOT. And I think the intention is for a QPQS to determine the severity of the shunt.
Yeah.
And as you can see, the VTI is far greater than on the right side compared to the left, which is abnormal and would be consistent with a significant shunt.
Yeah, 100%. And I think that is a crucial point that you've made or highlighted, essentially, is that if you see in any images, it doesn't have to be in this, in this case, but in any other, when you do your transthoracic echo studies, and you note that there's the RVOT VTI, which is much higher than the LVOT VTI, you should be looking, or should be fishing for a shunt. It's a shunt until proven otherwise, unless you've done the measurements incorrectly, which obviously we all know that can happen. But if you've done it correctly, and you've measured it appropriately, then if there's a difference and the RVOT VTI is higher, you should be looking for a shunt. Okay. Now, how do I know that this is a good profile and I'm accurately measuring it in the appropriate positions? I'm not, because obviously you know that if I'm too deep into the LV cavity, then obviously I'm going to get a different profile, VTI profile, and obviously the same thing with the RVOT profile. How do I know that I've done the I'm keeping with the standards?
Look, probably the best are the top left and the bottom images. The waveforms are about 2/3 of the image, which are appropriate. But you can see the closing clicks, which indicate that your sample volume is at the correct location.
That's exactly right. So making sure that the sample volume is correct, and the way you know that it is correct is that you need to have a closing click. Here, I'm not too sure. I can see a closing click, maybe. And again, I don't see a closing click there, but there's a closing click there. But this is probably the best example where I can clearly see a closing click, and that's how I know that I've got an appropriate my sample volume is in the appropriate position. If I've gone too deep, what will happen is that I'll also get another opening click as well, and then you're probably measuring you're too far in. So ensuring that you've got a closing click is key. Make sense? All right, moving on to the next case.
Sorry, Shanthosh, just a quick question. I'm surprised that there was mostly systolic flow between that VSD. It tells me that there's perhaps some chronicity, maybe some pulmonary hypertension. Is that fair to say?
Yeah, you're quite correct. I think it also depends on the infarct size, and depends on how large or small the infarct is to generate the pressure or the across that gradient. So obviously, if you've got an LV, if you've got a giant infarct and LV is down, then the pressure gradient across that VSD is going to be low as well. So it depends on the infarct as well. And you're right. It also depends on the whether there's some chronicity to it, in terms of whether they've had any history of primary hypertension or another concurrent pathology going around, associated with it.
And like, just for everyone to be on track, correct me if I'm wrong, Shanthosh, and with your question, Drew, but during systole, you've got such a large pressure differential between your left and right ventricular cavities, so you're going to have that left to right flow. During diastole, the pressure flow, the pressure differential between the two cavities will be smaller, but the left should still be higher than the right, even in diastole, so you should still get some flow from left to right across that VSD. And the fact that if you're in alignment and you've got a really good interrogation point through that BSD and you fan through it in all planes, and you're capturing no diastolic flow, it implies that there's no pressure differential across those two cavities.
Yeah, 100%. But it's a great question because it does, it's an important thing to think about and to be mindful of. All right. So this case is cracker. I really enjoyed this one. 65. I'm trying to emulate Sam or Sam's intensity, right?
Nice.
Like
We need peppermint tea.
yeah. Or Emma's enthusiasm.
Yeah.
So yeah. Hit the like button.
Comments down below.
Yeah.
I hope he watches this.
I'm not sure. Anyways, 65-year-old male with Southeast Asian heritage sent by in GP with chest pain, onset of central chest heaviness at 11. Went to the GP who did an ECG and then called the ambulance. Pain was associated with diaphoresis and dyspnea. He initially had pain 2 weeks prior, but didn't do anything about it. On the presentation, he had ST elevation on V1 to V5 with deep Q waves. All right, so can I pick on Rob this time?
Sure.
Tell me what's going on.
Okay, so image on the left is a parasternal long axis. The frame rate's not great, sorry, on my screen, but I can see that it appears that the ventricle is contracting. So the anterior septal and inferior lateral walls appear to be thickening during systole, which would be what I'd expect. And then I can't see any valvular abnormalities. The RV looks normal size, as does the ascending aorta and left atrium.
Right.
The parasternal short axis view. So given the history, I'm going to be looking for regional wall motion abnormality. So this is at the level of the mitral valve. So at the base of the left ventricle. And I'm concentrating on the anterior segments given the ECG changes. And maybe I can convince myself that there's some hypokinesis at the anterior and anterior septal wall, but I'd want to see that in other images.
Right. And I agree with you. It's not that obvious there. And again, just to, put your mind at ease, there's no significant valvular abnormalities across the mitral valve. And the 2D short axis view, it's just below the pat muscle, so it's almost pointing towards the apex. It's not that clear, so I wouldn't go back.
Yeah, back one.
Yeah, sure.
With the parasternal long axis view there, do you think that the anteroseptal wall and the infralateral walls are moving the same? Do you think they're both like contracting and thickening the same?
Perhaps not the anterior septal wall. It's difficult to see on this picture, but it might just be moving without thickening on this picture. Yeah.
I mean, I personally really like short axis looking at regional walls. I find it much easier than the long axis or the apical views. Obviously, it's got its limitations to look at everything multiple planes, but I would question whether that anteroseptal wall is actually thickening. There is some probably some near field clutter and some overgaining at the top of the sector that's making it a little bit hard to see. But I think that the infralateral wall there is thickening up pretty well. I think the anteroseptum probably isn't thickening up as much as it should in on that.
Yeah, I think you're probably correct. And anything about the wall itself? Is there a difference between the anteroseptal and infralateral walls?
It looks like there's perhaps some septal wall thickening.
Yeah.
Yeah.
It looks a bit chunkier and almost more edematous. And we'll get to that a bit later on, but I agree. All right, what about this one?
So we got our apical 4 chamber, and then on the right-hand side, focusing on the RV. So just concentrating on the left-hand side image first. So the inferior septal and anterior lateral walls appear to be thickening nicely. The apex is maybe akinetic, which could be in keeping with the history. the mitral valve looks to be coapting well. Now, on the right-hand side, the RV free wall and longitudinal function appears preserved. The tricuspid valve is coapting normally, and it's of normal size, the RV. So that's what I'd say about those.
Anything else on that 4-chamber view? And I agree. I mean, all the things you've said is correct. I mean, the apex looks akinetic. In other words, it's not moving at all. But anything else that is of importance?
There could be some spontaneous echo contrast within the LV, perhaps, or it might be an overgained image. And then there's something within near the apex. And if that's, with an akinetic apex in the history, I'd be wanting to interrogate further for whether there's a thrombus there.
And how would you do that?
To do that, I would use echo contrast.
We're too poor.
What'd you say?
I said we're too poor. That's money.
You can use some agitated saline, but yeah, I would optimize my 2D image. I'd zoom in and put my focus in the right spot, and then you could use some agitated saline to see if there's a thrombus forming.
Although you may not get that through the lungs.
True. Sorry. How else could you do it?
Hopefully you won't actually.
Color. You could use. No, you shouldn't. You're right. Sorry. You could use color flow Doppler.
You could.
But yeah, the gold standard would be to use contrast.
You're 100% correct, Rob, and you've said all the right answers. So it's quite important. I mean, you do have some spontaneous echo contrast, and can everyone see that smoky haze that's coming? Where's my mouse? Smoky haze that's coming down the LV. And with that history, as Rob said, you'd be very suspicious of a thrombus that may be forming or has already formed in the apex with an akinetic apex. So you'd be really suspicious of it, and so you'd have to really, zoom into it, change your focus position, and really pan through that apex to really have formed in the apex with an akinetic apex. So you'd be really suspicious of it, and so you'd have to really, zoom into it, change your focus position, and really pan through that apex to really have a good view. But the gold standard is, as Rob said, you need to do a contrast echo. Does this help with your suspicion at all? And you're right in terms of your gain settings. And that happens. You may have overgained, and so you do have to reduce your gains. So, but in this case, what do you think, Rob?
So we've got the 2-chamber on the left and the 3-chamber on the right. Again, I mean, there's spontaneous echo contrast within the LV. I'd want to zoom in further to see if there is a thrombus forming. So that nicely zoomed in picture, which you've just gone past, but they're focusing at the apex. It appears like there is a thrombus forming at the apex. Not so clear on these images.
Would you put your money on this?
The image prior looked more convincing. I would personally want to also see it with contrast, but I'm not very experienced at diagnosing this with certainty. So I'm not sure, but it appears like there is a mobile area, and particularly at the apex where I'd be concerned given the history and the imaging of an apical thrombus there.
Yeah, and I think you're quite right. I mean, contrast echoes is a bit harder. This is just a lot of swirl, so this also tells you that the blood flow in that apex is so slow, and and you're sitting dark for a thrombus there, and that's what you saw with the spontaneous echo contrast, the sec that you saw, that blood flow, that's all that blood swirling around. If I can probably draw your attention, if where my mouse is, in that apex, see that laminar thrombus sitting there. And that is, as Rob said, it is quite correct. I mean, you've got the apex that's akinetic, you've got sec, you've got poor flow, you've got Werco's triad there. So, I mean, you're going to have a thrombus developing. So, before I show the complete angio images, do you know which artery that I'm going to be most likely looking at?
The left anterior descending artery.
Yeah, 100%. So this is a cath of the same patient. This is the left circumflex that is coming down towards you. They have disease everywhere, to be honest. There's an intermediate vessel, but just where my mouse is, you may convince yourself that there should be a nobbin there. Okay, and again, just there where my mouse is on the right-hand picture, this is what's called a spider view. Your LAD should be coming off in that projection or that trajectory there. So it is completely occluded right at the ostium. And so they've wired it. They've got a whole lot of thrombus there, and they've put a whole lot of stents into that region, into the LAD, into the mid segment, and you've got better flow, but the problem is that you've trashed that apex, and that apex is probably dead, from a couple of weeks ago. And that from the history, that from the ECG. You've got Q waves, deep Q waves, which shows that this is an old infarct or at least subacute to chronic. So this didn't happen today or yesterday. So I'm not sure how much you're going to salvage that region. So this is a watch this space, but they've stented it anyway because they've had pain. So but that is in keeping with the ECG, the clinical history, and the echo findings. And the main thing in this case is that this patient has an apical thrombus, which changes our management because they'll need warfarin, right, for their management of the thrombus. And so then you need to be mindful of triple therapy and so forth, but that's a side story.
Does this person get warfarinized for life?
Yeah, it's a good question. I think they get 6 months and they get a rescanned to see if it's gone or not. But the key in this case is that based on the history, even with the other VSD, you need to do off-axis imaging to really try and pan through, because when you're doing this scan, your index of suspicion should be high. Well, hang on, my apex is down. It's completely akinetic. I'm going to be sitting dark for a thrombus. Even if I don't see a thrombus on the initial images, and even if I don't get that, typical finding of sec, I'll still be doing a contrast echo to make sure that there's no thrombus. And to be honest, majority of the time, like there's a study that's been done where patients have had MRIs post STEMIs. There's been a couple of subclinical thrombus picked up on MRI, but hasn't been picked up on TTE. So the number of TTEs that we probably miss with those akinetic apex, which probably have thrombus, be much higher than what we suspect. Anyways, does that make sense so far in that picture, or in that case? Any questions so far? Nope. Great. Let's go to the next case. So, 50-year-old male presented with 10 out of 10 chest pain 1.5 hours ago, radiating down the left arm. They've got a previous risk factor of hypercholesterolemia, pre-diabetes, and smoker. The cath lab was activated for STEMI. That's all the information that you're going to get. All right. So, who else is there? Yeah. Hani or Rishi? Hani?
Yeah.
If one of you guys want to volunteer?
Otherwise, I'll do it.
Oh, Rishi doesn't have a mic. So
how convenient, Rishi.
Yeah. Oh, Ben? Yeah.
Yeah, look, I'll talk through this one. Sure.
What do you see?
So I've got a series of transthoracic echo views ranging from a parasternal long, parasternal short, just below the pap muscles, 4-chamber and a 2-chamber. The most striking feature to me is that there looks to be a inferior infraseptal regional wall motion abnormalities. It's most pronounced in the short axis view. It's also evident when looking at the 4-chamber view. And when you come around to the 2-chamber view, where you've got your anterior wall on the left-hand side of the sector, which is partially obscured. Sorry, right-hand side of the sector, that one. Which is partially obscured by some artifact there, probably coming from lung. You can see that looks to be contracting well during end systole. It's come right in. Whereas the inferior wall on the opposite side of the sector is moving in but not thickening at all. It's getting pulled and tugged, and you can almost pick a point just coming around to that inferior side of the apex in there, where it looks like it transitions from thickening to not thickening, just pulling.
It's like hinge point almost.
Yeah, so this looks like this patient's got an inferior infarct with akinesis of those segments. And the 2-chamber, sorry, the short axis view at the top of the sector, or top of the screen above that, yeah, again, whilst it's a bit hard to pick, it does look like that there is some reduced movement and reduced thickening in the inferior regions. On that alone, on that short axis alone, I probably wouldn't call it. I'd just say it's probably not quite right, but I wouldn't be convinced just in that. Whereas when I come around to the apical views here, I think that cements it better for me.
Yeah, 100%. You're quite correct. So the parasternal long, I can't see any obvious regional wall motion abnormalities. Maybe the infrabasal segments might be a bit more hyperkinetic, but I'll definitely look at other views to have a look at that. The short axis, there's a bit of dropout, so it's not that clear, but I'm going to be looking at thickening, and the anterior and the lateral walls are thickening much more than the inferior walls. So, but it's not clear. And again, as Ben said, I'm going to be just looking at other views. In the 4-chamber, you can definitely probably see the basal and the infraseptal walls are hyperkinetic compared to the lateral and the apex. So that's a bit more contractile. But the 2-chamber is probably a bit more of a better clincher. You know, you've got the anterior and the inferior wall's not really contracting at all, or hyperkinetic. So I'm looking at, you know, regional wall motion abnormalities, but also looking at the thickening. Based on this, like, do you think this is acute? Is this chronic? Like, what features are you going to be looking at to tell the difference?
Look, I think that at the end of the day, I think it's actually hard, and you got to go back and look at the history and your ECG, work out when the chest pain was, that sort of thing. However, there are some echo features. So if you've got thinning of the endocardium, if it's literally thinner, and if it's more echogenic, so if it's whiter, then to me they're signs of chronicity. So if I'm seeing a thinner, like a rim of darker, or sorry, not darker, of whiter, more dense tissue, then I'm more suspicious that this is subacute to a chronic process. And I think in the parasternal short axis images that we have at the top right of the screen, it kind of looks like there is an element of chronicity to this. It does look a bit wider and thinner.
Yeah, maybe. Although the history doesn't say so. History doesn't fit that, but you're right. Anything else on the 4-chamber views that you may help to differentiate whether this is acute or chronic? Like apart from the walls, are there any other parameters?
So you could look at sequelae of it. So you could look at things such as, is there thrombus? Is there aneurysms? Is there tethering of the valves and some of the papillary muscles, depending on where your infarct is? Because to me, again, that is a sign of chronicity. If you're starting to get some tethering of the annuli and things like that. That's all I've got.
What about the LV chamber size or the LA chamber size?
Yeah, so you can get dilation of your chambers, assuming you don't have any known underlying cardiac disease. You can start to blow out your chambers. You can get dilated left ventricle, left atrium.
Yeah.
It can be for many things, but they come up with the secondary to ischemic disease.
Exactly right. So, if they've got ischemic cardiomyopathy, or have got, and sometimes what you might find is that the LV cavity itself is dilated or mildly dilated, particularly if there's an element of chronicity. The LA can be a good sign of chronicity as well. Remember, like it is like an HbA1c of chronic heart disease and whatnot. So if the LA chamber is dilated, it suggests that there was element of left atrial pressure, which has been there for some time. the LA doesn't blow up just suddenly overnight or the day or over a couple of days. So it does take a bit of time to dilate. So that's another those features that you may see on the 4 chambers or on the 2 chamber to suggest or to tell you whether this is acute or chronic, because it's important to tell or differentiate this, including the clinical history. So based on this, I've almost probably given you the territory that's involved. What do you suspect?
I mean, from an imaging point of view, I'm seeing inferior hypokinesis and akinesis. That's right coronary artery territory. Coupled with that, you can get rhythm changes as well. This person, it says 66, 64 there. Yeah. So, and it looks sinus. So the rhythm is preserved for now, which is great. But I'd expect to see a right coronary artery lesion.
Yeah, 100%. So this is a coronary angiogram of this patient, and what you can see is that this is the catheter that's coming down. The right coronary is completely occluded, right? So that's 100% occlusion. This is of the left system. They've got disease elsewhere, and including the LAD that is going down and supplying the apex. So that's how I know that it's the LAD. And the other factor I know it's the LAD. It's got septal branches coming off on one side and diagonal branches on the other side. Again, the LAD is not normal. It has disease in there. But the culprit, is the right coronary artery, and this is in keeping with your echo changes. And actually, I didn't tell you where the ST elevation was. It was actually on the inferior segment, so inferior territory. So putting all the history together, you know that the culprit's going to be the right coronary artery. And that's important because sometimes you can have multi-vessel disease, and you don't know which is the culprit artery. And so you really have to look, and we do a bedside echo, or the person on the other end is saying, look, the inferior segments are hyperkinetic, and the ST elevations are in the inferior territory. I really think that this might be a right coronary artery occlusion. And so that's quite important. So on the right bottom panel, they've wired it, ballooned it, and they've stented it so that they've got now flow across into the right coronary artery. All right, does that make sense so far? Any questions? Great. Maybe one last case, and then we can probably call it a day. So I think this one. Yeah, okay, this is cool. So 41-year-old AG presented with central chest pain following gardening. Risk factors of ischemic heart disease. It was in sinus rhythm with ST elevation. Oh, before I move on, Ben's brought an important point in the other factor. I mean, the inferior infarcts, they can have a lot of other complications, including heart block. They can be quite hypotensive, so they need a lot of RV filling. And so they can be quite hemodynamically unstable. So I thought that I'll mention that. It's quite important. Anyways, so this patient, sinus rhythm with ST elevation. Again, I won't tell you exactly where it is. All right. Since all of you guys had a go, anyone? Nothing tricky about this one, I think.
Come on, Peter, back to you.
All right, I'll do it. So it's 2 transthoracic images, a parasternal long and a parasternal short at the level of the papillary muscles. I can see, I'm going to start with what I can see. The valves look like they're moving well. The atria doesn't look massive. I think that the frame rate's not amazing. I think that the anteroceptal wall is maybe a bit hypokinetic. And on the parasternal short, it looks like that's the case as well. But there's a bit of dropout. I can't quite see the entire septum, but I want to see it in some other views. And overall, the LV function looks like it's probably preserved.
Yeah.
So some apical images, 4 and 2 chamber. Maybe the left atrium does look a little bit big. I think that again, so now the infrareceptal wall, it looks hypokinetic or akinetic, and the rest of the heart looks like it's compensating. The right looks like a normal size with normal contractility. And in the 2 chamber, again, I think the inferior wall is hypokinetic and maybe looks a little bit like it's a bit bright, like a high sort of brightness. I can't quite see the apical wall on that image, but if it's in keeping with the rest of what I'm seeing, I'd say it's probably got normal contractility.
Yeah, in the 4 chamber, which segment is probably the most hyperkinetic?
I think it's the basal and mid infraseptum.
Yeah, 100%. I think I probably agree with you there. And it is a bit difficult to say. I mean, you can't really see the lateral wall as clearly as you'd like, but I think it is coming in nicely there. And you can definitely see that mid-septum, the apex, that's all coming in nicely. And the way I know that, I'm just putting my pointer or my mouse in and to see whether everything is coming towards the middle or towards the mouse. And that's probably a good way of just seeing if everything's equally contracting, and probably the basal and the mid infraseptum is not as hyperdynamic or hypercontractile as the other segments. So and this is a 3-chamber view, and I think I probably agree with you still there. So the patient had an inferior STEMI, the troponin peaked to 4,600, and they essentially had another inferior infarct. And you've already seen an inferior right coronary artery that was completely occluded. So they had a similar segment. Sometimes the circumflex lesions can present as similar. I'm not sure if no, I don't. Circumflex lesions can also present in a similar fashion. So it can be quite tricky to delineate that. And sometimes that can be quite difficult to understand. So we've gone through regional wall motion abnormalities, which is sometimes quite difficult to try and pick out or to try and understand. But hopefully I've given you some of the cases that are it makes it a bit more easier to understand, and some correlating angiograms, because that may help you understand exactly what's going on and what you may find. A VSD, which is quite important, a complication. It's a rare complication. We don't see it as often, but sometimes with the rare presentations, you should be thinking about this. And the most important thing about that case is you have to really pan through the vessel, because remember the 5 images that I showed you initially, you couldn't tell that there was a VSD. It was only on subsequent images that there was hang on, there is a defect in the short axis, and then we should be looking at it. But also the history gave it away that this patient continues to be in multi-organ failure, hypertensive, despite the LV being preserved. So you really had to go fishing for it to try and find out what's going on. The septum with the akinetic apex with the thrombus, Rob's clearly demonstrated the fact that this is this patient was a sitting duck for a thrombus with the sec, and just making sure that, again, off-axis images, focus position, moving it to the apex, and really zooming in on that image to try and figure out is there a thrombus or not. And if you can't, to be honest, if you're not sure, the gold standard is a contrast echo. And then the first case that we talked about is a papillary wall rupture muscle. And it is a rare complication, but it happens. These patients become quite hemodynamically unstable, and understanding the pathophysiology of it and the free-flowing MR, and just identifying it early so that you can institute appropriate therapy, and that may make a difference for the patient. So those are some of the complications, the echo findings that hopefully you have a better understanding of. There are obviously other complications associated with MIs. We haven't talked about tamponade or pericardial effusions, and that's an important differential to really look at in this case and trying to figure out. And I think, and I'm sure there'll be a case or
there is a talk about
tamponades and stuff. Cardiogenic shock with poor LV dysfunction, and they can have electrical disturbances as well, so which we're not going to talk about. But so this is hopefully gives you an overview of some of the things. But any questions, Ben?
Can I ask one I should start with? And it's less directly related to echo, but more to that last case. So if that last patient was 41 years old, which is relatively young, and I know that the population that we have around here, I know up in far north Queensland, because I used to work up there in Cairns, I'm sure Rob in Darwin and is very similar. Patients can have enough coronary artery disease risk factors to have occlusions and ischemic heart disease at this age, but could this have been spontaneous coronary artery dissection?
Yeah, it's a good question. It could have been, but then on the angio images there was a complete occlusion of the right. Yeah. The profile is also he was a 41-year-old male. Yeah. Generally this occurs in young females. Yeah. and so it wasn't as, it's not a common finding in males, but you definitely can.
And do you know, because I've seen that with ECG changes, but do they get regional walls as well?
100%. So spontaneous coronary artery dissections, for the guys who may not be familiar with that term, it's just a tear in the intima wall of the coronary artery, and you can get just a slight tear, and they will present exactly the same way as any other acute coronary syndromes or ST elevations. The only way you can diagnose it is by doing the invasive coronary angiogram. They will also get regional wall motion abnormalities. They'll present exactly the same way as any other occlusion or occlusive disease, but the management is quite different. You don't stent these guys; you just medically manage them.
Yeah, right.
Because the danger obviously is that you propagate that dissection further down or proximally. So yeah. Okay. Any other questions, guys? Not a problem, Rishi. Thank you. So hope that helps. I wish you all the best in your DDU journeys. And yeah, we may see you guys at some point later on. But yeah.
Thanks so much.
Thank you.
Thank you so much.
No worries. See you guys.
Bye.